Welcome to the deep dive. Today, we're taking a really in-depth look into something that touches almost all of us at some point, the incredibly complex world of perioperative care. Think about it, that moment just before surgery, maybe you feel a little bit anxious.
Sure, that's common.
But what you might not realize are the sort of invisible threats lurking and the amazing, highly sophisticated medical strategies working hard to protect you.
Absolutely. It's a whole system designed for safety.
So our mission today is to unpack these key areas. We're drawing from comprehensive medical texts, the latest guidelines on things like perioperative antibiotics, antiemetics, those are the anti-nausea drugs.
Right.
And also the critical considerations when patients are on psychiatric medications during surgery.
Yeah, that's a really important one.
Our goal is basically to help you understand not just what happens, but why it matters. We want to give you that deep, actionable understanding, almost like an elite professional in the field.
That's right. By the end of this deep dive, you'll grasp the hidden costs, both human and financial, of surgical site infections.
Okay.
And you'll understand the nuanced science behind preventing that really unpleasant nausea and vomiting after a procedure.
Nobody wants that.
Definitely not. And you'll also get a real appreciation for the delicate balance needed when patients on psychiatric meds undergo anesthesia. It's a fascinating intersection of pharmacology and human physiology.
Requires incredibly careful practice, I imagine.
It really does.
So let's start where the stakes often feel highest, that unseen battle against infection. We'll focus specifically on perioperative antibiotics.
Good place to start.
And to kick us off, we need to understand the sheer scale of the problem. I'm talking about surgical site infections, or SSIs. How big a deal are they? Perioperative antibiotics. The unseen battle against infection, perioperative antibiotics. The significant burden of surgical site infections, SSIs.
Oh, they're a very big deal. Surgical site infections are far from just a minor issue. They represent a really significant burden, both for the patient and for the healthcare system overall.
Okay.
When you look at all the infections that can happen around the time of surgery, SSIs are, well, they're the most common type, by far.
Most common, wow.
Yeah. And here's a pretty startling fact. They are also the #1 reason for hospital readmission after surgery.
Get out. Really?
Yep. They account for nearly 20% of all unplanned readmissions.
20%. That's huge. Just think about the ripple effect. A patient readmitted needs a bed, more resources.
Exactly. It's a huge drain. And for the patient, it's a setback in recovery, plus the fear, the discomfort.
Yeah, the personal toll.
It's significant. The statistics really drive this home. In the U.S., we're talking about an estimated 157,000 SSIs every year.
157,000.
And each one, on average, adds about 7 to 10 days to the hospital stay.
An extra week or more.
Right. And nationally, that translates to an estimated annual extra cost of, wait for it, $3.3 billion.
A billion. With a B.
With a B. The average added cost per SSI is around $21,000.
$21,000 for one infection.
But, for the deeper, more complicated infections, that cost can easily shoot past $41,000.
Incredible. It's just staggering to think about the economic and, well, the human cost of something that maybe sounds small, like an infection after surgery.
It's a massive drain on resources. And tragically, it's also a serious threat to life.
How serious?
Well, the mortality rate associated with SSIs is 3%.
3% die.
Yes. And of those deaths, about 3/4 are directly attributed to the infection itself.
Wow. So this isn't just about recovery time or money. It's literally life and death.
It absolutely is, which just highlights how critically important prevention is. Be defining and classifying surgical site infections.
Okay, so when we talk about an SSI, what exactly is the definition? Is it just any old infection after surgery?
No, it's much more specific than that. The CDC, the Centers for Disease Control and Prevention, they have a very meticulous definition. An SSI is an infection that occurs within the operative field after surgery.
Within the operative field, got it.
And they break it down further into 2 main categories. Incisional SSI and organ space SSI.
Okay, incisional. Sounds like it's right at the cut, right?
Exactly.
Yeah.
And even that is subdivided based on depth. A superficial incisional SSI is just limited to the skin and the subcutaneous tissue, the outermost layers.
Okay.
But a deep incisional SSI, that goes further down. It extends into deeper tissues like the fascia, that tough connective tissue, and the muscle layers. Much more serious.
Right, deeper sounds worse. And what about organ space SSI?
So an organ space SSI is an infection that happens somewhere in the general area of the surgery, the operative field, but it's outside the actual layers of the body wall that were cut.
Oh, okay. So
Sure,
examples.
like if someone has abdominal surgery and develops an intra-abdominal abscess, a collection of pus inside the abdomen, that's an organ-space SSI.
Makes sense.
Or after chest surgery, maybe they develop empyema, that's pus collecting around the lungs. That's another one.
Okay.
Or maybe osteomyelitis, a bone infection, or a joint infection after orthopedic surgery. Those are also organ-space SSIs.
So understanding these different types is important.
Absolutely crucial. Because the location, the depth,
Yeah.
it all dictates the prevention strategies and, of course, the treatment if an infection does happen. C, understanding risk factors and common pathogens.
Okay, so given how serious SSIs are, what makes someone more likely to get one, and what are the main bugs, the pathogens causing them?
Right. So the CDC tracks this stuff through their National Healthcare Safety Network. What we know is that SSIs are multifactorial. Lots of things contribute.
Yeah.
It's usually a mix of patient-related factors and things related to the operation itself.
So let's talk about the patient factors first. What makes an individual more vulnerable?
Well, several things. Age is one factor. Nutritional status is important. Conditions like diabetes, especially if it's not well controlled, that significantly increases risk.
Okay, diabetes, age, what else?
Smoking is a big one. Obesity, too. Even having another infection somewhere else in your body, like a UTI before belly surgery, can raise the risk.
Really? An infection somewhere else?
Yeah. Being colonized with certain bacteria, meaning they're on your skin or in your nose, but not causing illness yet, can be a factor. A weakened immune system, obviously. Even how long you stay in the hospital before the surgery can matter. And finally, hypothermia, getting cold during or around the time of surgery, that can weaken the body's defenses too.
Wow, that's quite a list.
Hmm.
It really shows how the patient's overall health matters so much going in.
It really does.
Now, what about the operational factors? What happens in the OR?
These factors really highlight the huge responsibility of the surgical team. I mean, everything matters. How long the staff scrub their hands, how well the patient's skin is prepped,
Okay.
whether hair removal was done, and how. The length of the operation itself, longer surgeries generally mean higher risk.
Makes sense. More exposure time.
Exactly. Giving the right antibiotic at the right time. That antimicrobial prophylaxis is absolutely critical.
We'll come back to that.
Definitely. Then there's OR ventilation, making sure instruments are perfectly sterilized, avoiding foreign materials in the wound. Even things like surgical drains can increase risk.
It sounds like meticulous technique is key.
Absolutely. The surgeon's technique, controlling bleeding well, closing up any dead space where fluid could collect, minimizing tissue trauma.
Yep.
It all plays a part.
It really is like a complex equation. So who are the usual suspects? The common bacteria.
The number one culprit, the overwhelming leader, is Staphylococcus aureus, often called Staph aureus.
Okay.
It accounts for about 30% of SSIs and other hospital-acquired infections. It's the main target for a lot of the preventative antibiotics.
30% is a lot. Who else is on the list?
You also see coagulus-negative staph, various Enterococcus species, E. coli, Pseudomonas aeruginosa, and Enterobacter species.
Okay, mixed.
Yeah, and even a fungus, Candida albicans sometimes, plus Klebsiella pneumonia, certain anaerobes, Proteus mirabilis. So while Staph aureus leads, there's a whole cast of characters depending on the surgery type.
And I understand there's also a way to classify the surgical wounds themselves. How does that help?
Yes, that's the surgical wound classification system. It's incredibly important because it helps predict the risk of infection and guides whether antibiotics are needed and which ones. There are 4 classes.
Okay, walk us through them.
Sure. Class are clean wounds. Think of these as uninfected wounds where there's no inflammation and you haven't entered internal tracts like the gut or respiratory system. Usually close right up, like a simple hernia repair maybe.
Okay, lowest risk.
Right. Then class 2 are clean contaminated. Here you do enter one of those tracts, respiratory, GI, urinary, etc., but it's done under controlled conditions without unusual contamination. Think biliary tract surgery, an appendectomy, vaginal surgery, as long as there's no existing infection or major break in sterile technique.
Okay, slightly higher risk because you entered a tract.
Exactly. Class 3 are contaminated wounds. This includes things like open, fresh, accidental wounds, or operations where there was a major break in sterile technique like emergency open heart massage outside the OR, or if there's significant spillage from the gut during surgery. Also includes incisions where there's already some acute inflammation, but no pus yet.
Okay, definitely getting riskier.
Definitely. And finally, class 4 are dirty infected wounds. These are old traumatic wounds with dead tissue or wounds where there's already an existing infection or a perforated organ like a burst appendix. Basically, the bacteria causing the potential infection were already there before the surgery even started.
Gotcha. So this classification really helps the team gauge the bacterial load they're starting with.
Precisely. And that directly informed the decisions about prophylactic antibiotics, whether to use them, and which ones are most appropriate for that level of risk. D principles of proper antimicrobial agent selection.
So given all those factors and classifications, choosing a right antibiotic for prophylaxis seems absolutely critical. What are the guiding principles there?
It's paramount. Yeah. The core principle is you want to target the most likely bacteria, the ones you expect to cause trouble for that specific surgery.
The most likely ones.
Right. You don't try to cover every single possible pathogen.
Why not? Wouldn't broader coverage be safer?
You'd think so, but it actually increases the risk of developing drug resistance. We want to use the narrowest effective weapon, basically, to preserve the effectiveness of our broader spectrum antibiotics for when we really need them. It's about minimizing resistance.
Okay. That makes sense. The bigger picture. So what are the ideal goals for a drug used for surgical prophylaxis?
Ideally, a prophylactic antibiotic should achieve 5 key things. First, obviously, prevent the SSI.
Right.
Second, prevent any complications or death related to that SSI. Third, it should help reduce the length and cost of healthcare.
Okay.
Fourth, it really shouldn't cause any harm or side effects to the patient.
A big one.
And fifth, very importantly, it shouldn't mess up the patient's normal bacteria or the hospital's microbial environment in a bad way, again, to fight resistance.
Those are pretty high bars, but necessary ones. So what makes an antibiotic ideal for meeting those goals?
Well, to hit those targets, the drug needs 4 key characteristics. 1, it has to be active against the most probable pathogens for that surgery.
Targeted activity.
Exactly. 2, it needs to be given at the right dose and the right time, so you get good levels in the blood and tissues during the time contamination might happen.
Timing and concentration.
Crucial. 3, it has to be safe. Low toxicity.
Of course.
And 4, it should be given for the shortest effective time possible. Again, this minimizes side effects, resistance, and costs. It's this constant balancing act: be effective enough, but not overly broad. Preserve our tools for the future. Delving into drug classification and mechanisms of action.
Now let's get into the really cool part, I think. How do these antibiotics actually work? Can you break down the main types and how they fight bacteria?
Absolutely. It's quite amazing the precision involved. Broadly, antibiotics fall into 2 main camps based on their chemical structure and how they work: beta-lactams and non-beta-lactams.
Okay, beta-lactams first. What defines them?
So beta-lactams all share a specific chemical structure, a 4-membered ring called the beta-lactam ring. This group includes really well-known antibiotics like penicillins.
Like amoxicillin.
Exactly. And cephalosporins like cefazolin, which we mentioned is super common in surgery. There are also others like carbapenems and monobactams.
And how do they work? What's their main trick?
Their main strategy is to interfere with building the bacterial cell wall. They inhibit specific enzymes called transpeptidases that bacteria need to link together the building blocks of their cell wall.
So they stop the bacteria from building their protective wall.
Precisely. They sabotage the construction process. Without a strong, intact cell wall, the bacterial cell basically loses its structural integrity and falls apart, leading to its death.
Like taking bricks out of a wall until it collapses. Okay, and the non-beta-lactams, how are they different?
These are chemically distinct from the beta-lactams, and they employ a wider variety of tactics. While beta-lactams focus on the cell wall, these other drugs go after different essential processes within the bacteria.
Okay, give us the rundown. What other targets do they hit?
Right, it's like having different types of special forces targeting different enemy systems.
Ah, okay.
So some drugs, like glycopeptides, vancomycin is the big one here. They also target the cell wall, but they do it a bit differently than beta-lactams. Still disrupts wall building, leads to breakdown.
Okay, another wall attacker.
Then you have drugs targeting the cell membrane itself. The polymyxins, like colistin, are examples. They mess with the outer membrane of gram-negative bacteria, kind of like punching holes in it, making it leaky and unstable.
Disrupting the outer defenses.
Exactly. Then a really large group targets the ribosome. That's the machinery inside the bacteria that makes proteins.
Protein factory.
Right. By jamming up the ribosome, these antibiotics stop the bacteria from making essential proteins, which halts their growth and reproduction. This group includes aminoglycosides like gentamicin, macrolides like azithromycin, and tetracyclines like doxycycline. Each class binds to slightly different spots on the ribosome, but the end result is shutting down protein production.
Stopping them from multiplying.
Yes. And finally, you have antibiotics that target DNA synthesis and structure.
going after the genetic code.
Exactly. Fluoroquinolones, like Cipro, inhibit enzymes that bacteria need to unwind and copy their DNA, basically preventing replication. Antiphthalates, like Bactrim, interrupt the production of the building blocks needed for DNA. And nitroglizols, like metronidazole, generate damaging molecules that break the bacterial DNA strands.
Wow, so many different ways to attack. It really is like molecular warfare.
It absolutely is. Each class has its specific targets and mechanisms, allowing doctors to choose the right weapon for the right bacterial enemy. Quality Improvement Initiatives, the Surgical Care Improvement Project, SCIP.
Okay, so given the huge impact of SSIs we talked about, there must have been efforts to, standardize prevention, right? I think I've heard of SCIP.
Yes, absolutely. The Surgical Care Improvement Project, SCIP. It was a major national quality partnership launched back in 2006. The whole goal was to reduce surgical complications with a big focus on SSIs by getting hospitals to follow specific core measures.
Core measures, so like a checklist of best practices.
Pretty much. They're evidence-based clinical guidelines. Things hospitals were supposed to track and report nationally.
Yeah.
Key ones included making sure the prophylactic antibiotic was given within 1 hour before the incision.
We talked about that timing.
Right. Making sure the correct antibiotic was chosen. Stopping those antibiotics within 24 hours after surgery ends.
Also important.
Yeah.
Yeah.
Others focused on things like controlling blood sugar after cardiac surgery, using appropriate hair removal methods, keeping patients warm during colorectal surgery, getting urinary catheters out promptly, managing temperature overall, and preventing blood clots.
Sounds very thorough, like a really solid plan based on evidence. So did it work? Did SCIP lead to lower infection rates?
Well, that's the surprising part. Despite this huge national focus and widespread adoption of these SCIP measures, there hasn't actually been a measurable improvement in overall SSI rates that we can definitively attribute to SCIP.
Really? After all that effort?
Yeah. It's a bit sobering. It really highlights just how complex SI prevention is. It's probably not as simple as just checking off boxes on a list. It definitely raises questions and shows that we still need maybe newer or perhaps more comprehensive approaches. It's not that the SCIP measures are wrong, but maybe they aren't sufficient on their own or aren't implemented perfectly everywhere.
Gee.
The power of bundled interventions for SSI prevention.
Okay, so if SCIP alone didn't quite crack it, what's the next step? I've heard the term bundles or bundled interventions being used more. What's that about?
That's exactly where things have been moving. The idea behind bundles is to take multiple evidence-based practices, group them together, and implement them consistently for all patients undergoing a certain procedure or in a certain setting.
So instead of just one thing, it's like hitting the problem from multiple angles at once.
Precisely. It's a holistic approach.
Yeah.
The thinking is that these measures work synergistically. The combined effect is greater than the sum of the individual parts. You're building layers of protection.
Makes sense. What kinds of things typically go into an SSI prevention bundle?
It varies a bit, but common components include things done before surgery, like screening patients for certain bacteria, maybe decolonization protocols to reduce the bacteria they carry.
Decolonization, like special soaps or nose ointment.
Exactly. Then, targeted antibiotic prophylaxis, proper skin prep, appropriate hair removal. During and after surgery, key elements are keeping the patient warm, avoiding hypothermia, and tightly controlling blood sugar levels. Effective preoperative bathing is often included, too.
So it's a much more comprehensive package deal. Do we have examples where this has actually worked?
Yes, there are some really encouraging examples. One often cited is a report from 2015 from a large medical center. They put together a bundle specifically aimed at reducing infections related to central venous catheters in their ICUs.
Okay, catheter infections. What was in their bundle?
It was quite comprehensive. Strict hand hygiene, ongoing staff education, using chlorhexidine for skin prep, using maximum barrier precautions during insertion, having a dedicated cart with all the supplies ready, using a checklist.
Checklists again?
Yep. Avoiding the femoral vein in the groin if possible, using special chlorhexidine impregnated dressings, using anti-infective catheters when appropriate, and this is key daily checks on whether the catheter was still actually needed.
And did it work?
It led to impressive reductions in those catheter-related bloodstream infections. It really showed the power of that multifaceted, layered approach.
That's great. So it's not just the surgeon, right? It sounds like the whole team, including anesthesia providers, plays a big role.
Absolutely critical. The anesthesia provider's role is huge. Studies have actually linked bacteria transmitted from anesthesia workstations to infections occurring up to 30 days after surgery.
Wow, from the anesthesia equipment.
Yeah, potentially from reservoirs on the equipment.
Yeah.
So anesthesia providers need to be implementing their own bundles. essentially. Things like double gloving during airway procedures, meticulous hand hygiene throughout the case, participating in patient screening and decolonization efforts, and ensuring thorough decontamination of their equipment.
So it truly takes a village. Every single person in that perioperative environment.
It really does. Everyone has a part to play in preventing these infections. Age-precise drug administration guidelines for prophylaxis.
We've talked about choosing the right antibiotic and using bundles, but you mentioned earlier how crucial the administration is, the timing, the dose. Can we dive deeper into those precise guidelines?
Yes, this is where the science gets really practical. The effectiveness of an antibiotic hinges heavily on its pharmacokinetics, how the body absorbs, distributes, metabolizes, and excretes the drug, and critically, the timing of when it's given.
I think I heard terms like time-dependent versus concentration-dependent killing. What's the difference?
Excellent question. Those are core concepts. Time-dependent killing means the antibiotic's effectiveness depends mostly on how long its concentration stays above a certain level, the minimum inhibitory concentration, or MIC, needed to inhibit the bacteria.
So sustained pressure.
Exactly. Think of it like keeping steady pressure on the enemy. Most beta-lactams, like cefazolin, work this way. You need to maintain those levels over time.
Okay. And concentration-dependent.
Concentration-dependent killing means the key is achieving a high peak concentration of the drug relative to the MIC. It's less about duration and more about hitting the bacteria hard and fast with a high dose.
Like a knockout punch.
Good analogy. Fluoroquinolones often work this way, and interestingly, vancomycin kind of shows both effects.
So that explains why the timing of the first dose is so critical, right? To get those levels up.
Absolutely. The standard recommendation is to give that first dose within 60 minutes before the initial surgical incision. That gives the drug enough time to circulate and reach adequate levels in the blood and tissues right when the skin barrier is breached.
Okay, 60 minutes. Always.
Well, there's a slight modification for drugs like vancomycin or fluoroquinolones because they often need to be infused slowly over a longer period to be safe.
Right. You mentioned vancomycin and red man syndrome.
Exactly. So for those, the infusion should start within 60 to 120 minutes before incision. That allows for the longer infusion time while still ensuring good levels by the time surgery begins.
Gotcha. What about redosing, like during a really long surgery?
Yeah, that's important too. You need to redose to maintain those therapeutic levels. The general guideline is to redose at approximately 2 half-lives of the drug.
2 half-lives. How long is that usually?
It depends on the drug. For cefazolin, the half-life is roughly 1.5 to 2 hours, so redosing would typically be around every 4 hours. Okay.
And because those beta-lactams are time-dependent killers, some experts even suggest using a continuous 5E infusion after the initial loading dose for long surgeries, just to keep those levels really steady.
Interesting. What if there's a lot of bleeding?
Good point. Significant blood loss can dilute the antibiotic or remove it from the body. So, more frequent redosing might be needed. A common recommendation is to redose after about 1,500 milliliters of blood loss, or maybe after roughly 30% of the patient's blood volume has been lost and replaced.
Okay, need to account for dilution. And how long should the antibiotics continue after the surgery is finished?
For most procedures, the duration of prophylaxis should be less than 24 hours.
Just 24 hours.
Yep. Continuing longer usually doesn't provide any additional benefit in preventing infection, but it does increase the risk of side effects and antibiotic resistance. So short and targeted is the goal.
That makes sense. Okay, so we have the principles. Can you give us a couple of concrete examples? How does this actually play out for, say, a very clean surgery versus a dirtier one, like operating on the colon? Excellent question. It really illustrates how the approach is tailored. Let's take a Class I clean surgery, like a standard inguinal hernia repair. Here, you're mainly worried about skin bacteria like Staph aureus or Staph epidermidis.
Right, the ones already on the skin.
Exactly. So for that, a single dose of an antibiotic like cefazolin, given within that 60-minute window before incision, is usually sufficient. The goal is simply to knock down any skin bugs that might get into the wound.
Okay, simple case, simple approach. Now, what about colorectal surgery? That sounds much dirtier.
Oh, absolutely. That's often Class 3 or even Class 4. The colon is packed with a huge variety of bacteria, gram-negatives, anaerobes, bacteria that live without oxygen, enterococci. It's a whole different ballgame.
So cefazolin alone isn't enough?
Definitely not. For colorectal surgery, you need much broader coverage. You'll typically use a combination of antibiotics. For instance, maybe cefazolin plus metronidazole. Metronidazole is specifically added to target those anaerobic bacteria that are so prevalent in the gut.
Covering more bases.
Exactly. And often, for elective colorectal surgery, there's more prep involved before the OR. Patients might undergo a mechanical bowel prep, basic cleaning out the colon, and also take oral antibiotics like neomycin and erythromycin the day before surgery.
Wow, cleaning from the inside out, too.
The goal is to drastically reduce the bacterial load in the colon before the surgeon even makes an incision. So you can see it's a much more comprehensive and aggressive strategy dictated entirely by the expected bacterial environment.
That's a fantastic illustration. It really shows the depth of thinking involved. It's not just one size fits all.
Not at all. And there are other critical nuances too. You always need alternatives for patients with allergies, right? Especially penicillin allergies.
Yeah, we'll get to that.
Dosing needs to be adjusted for body weight. Larger patients often need larger doses.
Makes sense.
You also have to consider local resistance patterns. If your hospital has a lot of MRSA, methicillin-resistant Staph aureus, you might need to add vancomycin. Even though Vanic isn't actually as good as cefazolin against regular Staph aureus, it's a trade-off.
So you have to know your local enemy.
Precisely. And finally, you're always weighing the benefits against the risks. Using very broad-spectrum drugs might kill more bugs, but they also increase the risk of nasty side effects like C. diff colitis, a severe diarrhea, and they drive resistance faster. So it's always a careful balance. Understanding antibiotic allergies in the perioperative setting.
Okay, you mentioned allergies. Let's tackle that. Penicillin allergy seems incredibly common. How does that complicate things in the OR?
It's a major consideration, yeah. Antibiotics are actually a leading cause of severe allergic reactions, anaphylaxis, related to anesthesia. About 15% of those reactions are due to antibiotics.
15%.
And get this, penicillins and cephalosporins together account for about 70% of those antibiotic reactions.
Wow, so mostly those two groups.
Mostly. And penicillin allergy is the most commonly reported drug allergy overall. Maybe around 10% of people say they have it.
1 in 10. That's a lot of patients needing alternative antibiotics.
Well, here's the really interesting part. More than 90%, 9 out of 10 of patients who report a penicillin allergy are found not to be truly allergic when they undergo proper skin testing.
90% aren't actually allergic.
Correct. And the likelihood of having a positive skin test actually decreases over time if you avoid penicillin. It drops by about 10% per year. So after 10 years, most people who might have been allergic are likely negative on testing.
So that label might be wrong for many people.
Very often, yes. And skin testing is safe and reliable for diagnosing those immediate, severe IgE-mediated reactions. This is critical because it means we might be unnecessarily avoiding really effective first-line antibiotics like cefazolin in patients who can safely receive them.
That's huge. What about cephalosporins like cefazolin? If someone is truly allergic to penicillin, can they get a cephalosporin? What's the cross-reactivity risk?
That's another area where understanding has evolved. The rate of actual allergy to cephalosporins is lower, maybe around 1%. Historically, people thought the cross-reactivity risk with penicillin was quite high.
Yeah, I've heard that.
But now the data suggests the risk of clinically significant cross-reactivity is actually quite low, probably around 3% or even less for many cephalosporins.
Why is it lower than previously thought?
It seems to depend on the specific chemical structure, particularly something called the R1 side chain. Many cephalosporins, including cefazolin, have a very different R1 side chain compared to the penicillins that usually cause allergies. So they're often considered safe even in patients with a true penicillin allergy.
So it's not a blanket allergic to one means allergic to all beta-lactams.
No, definitely not. It's much more nuanced and depends on the specific drugs involved. Of course, caution is still needed, and a thorough allergy history is vital.
Okay. And how quickly do these reactions usually happen if they do occur?
Good question. Immediate reactions happening within an hour are almost always the true IgE-mediated allergy, or sometimes a direct effect of the drug-stimulating mast cells, which release histamine. Reactions happening later, after an hour, can involve different immune mechanisms, including T cells. Knowing the timing helps figure out the likely cause and severity.
And you mentioned vancomycin and red man syndrome. That's not a true allergy.
Correct. Rapid infusion of vancomycin can cause flushing, itching, and low blood pressure looks like an allergy, but it's usually a rate-related infusion reaction. Slowing down the infusion typically resolves it. It's important not to mislabel that as a true allergy. Interactions between antibiotics and anesthetic drugs.
Okay, besides allergies, are there other ways antibiotics can interact with anesthesia drugs that the team needs to watch out for?
Yes, definitely. Patient safety depends on knowing these interactions. Some antibiotics can actually cause muscle weakness themselves, or they can significantly potentiate, meaning enhance or prolong the effects of the neuromuscular blocking agents, the NMDAs or muscle relaxants that anesthesiologists use.
Muscle relaxants might last longer. Which antibiotics do that?
The main groups known for this are the aminoglycosides, drugs like gentamicin, and also polymyxins, lincomycin, clindamycin, and tetracyclines. If a patient receives one of these and an NMDA, they might experience prolonged muscle weakness after surgery, potentially delaying their ability to breathe on their own.
Okay, good to know. What about the common ones, like penicillins and cephalosporins? Do they interact with muscle relaxants?
Thankfully, no. Cephalosporins and penicillins have not been reported to cause this interaction with NMDAs. That's reassuring given how often they're used for prophylaxis.
That is good news. So if that prolonged weakness does happen with one of the interacting antibiotics, what's the fix?
The primary management is supportive. You need to ensure the patient's breathing is adequately supported, usually with mechanical ventilation, until their muscle strength returns naturally.
Just wait it out.
Essentially, yes. And here's a crucial point.
Yeah.
You should not give calcium to try and reverse this specific type of blockade.
Why not calcium?
Because the antagonism it provides isn't sustained. And more importantly, giving calcium might actually interfere with the antibiotic's ability to kill bacteria, undermining the whole reason it was given. So supportive care is the way to go. It really underscores the need for that specific drug interaction knowledge. 2. Antiemetics and perioperative nausea and vomiting, PONV, calming the post-op storm. 2. Antiemetics and perioperative nausea and vomiting, PONV. A. The persistent problem of PONV and PBNV.
Okay, let's shift gears now. We've covered the invisible battle against infection. Now let's talk about something much more noticeable and unpleasant for patients. Postoperative nausea and vomiting.
PONV.
Ah, yes, PONV. And its equally frustrating sibling, PDNV, post-discharge nausea and vomiting.
Right, the misery doesn't always end when you leave the recovery room.
Unfortunately not. And despite huge efforts from the anesthesia community, these remain really significant clinical problems. They just make the whole experience so much worse for the patient.
Reduces patient satisfaction, I'm sure, greatly. And it's not just about feeling bad. PONV can actually cause problems. It can stress the surgical incision, especially after face, mouth, or brain surgery.
Oh yeah, that sounds bad.
It can lead to bleeding, mess up fluid and electrolytes, put stress on the heart, and in the worst case, lead to aspiration.
Aspiration, breathing stomach contents into the lungs.
Exactly. Very dangerous. Plus, PONV delays discharge from the recovery room, and PDNV can even cause patients to be readmitted to the hospital.
So it's a quality of life issue, but it also has real medical consequences and costs.
Precisely. It eats up resources, staff time, and drives up costs.
And I remember reading something surprising that the nausea and vomiting after discharge can actually be worse than right after surgery.
That's true, and it's often overlooked.
Yeah.
A major study by Apfel and colleagues looked at thousands of patients. In the recovery room, about 20% had nausea, 4% had vomiting.
Okay.
But after discharge, those numbers jumped to almost 37% experiencing nausea
Yeah.
and nearly 12% experiencing vomiting.
Wow, much higher after leaving. Why is that?
It's likely due to factors like increased movement, maybe starting to eat normal food again, the effects of opioid pain pills taken at home, and maybe the prophylactic anti-nausea meds given in the OR have worn off. It really highlights the need to think about longer-lasting prevention. B. Identifying risk factors for PONV.
Okay, so given how common and problematic this is, figuring out who's most likely to get sick seems crucial for prevention. What are the main risk factors?
You're exactly right. Identifying risk is step one. The PONV management guidelines really emphasize this. There are several well-established risk factors.
Like what?
Well, female gender is a big one. Having a history of PONV from previous surgeries or having motion sickness also significantly increases risk.
Okay, female, history of it. What else?
Interestingly, being a non-smoker.
Non-smoker. Why?
The mechanism isn't totally clear, but it's a consistent finding. Younger age is also a risk factor.
Okay. What about the anesthesia itself?
Yes, general anesthesia carries a higher risk than regional anesthesia. Using inhalation anesthetics, the gases and nitrous oxide also adds to the risk. And a major contributor is the use of postoperative opioids for pain control.
Opioids are notorious for nausea.
They really are. The duration of anesthesia matters too. Longer surgery, higher risk. And certain types of surgery are just more likely to cause POV gallbladder removal, laparoscopic procedures, gynecologic surgeries are often cited.
Okay, quite a few factors. It seems like someone could easily have several of these stacking up.
Exactly. And the more risk factors a patient has, the higher their baseline risk of PONV.
Are there any things that people thought were risk factors but maybe aren't?
Yeah, it's good to clear those up. There's conflicting evidence on whether things like the menstrual cycle, how much experience the anesthesia provider has, fasting times, BMI, or anxiety are independent risk factors.
Okay.
And some things have pretty much been disproven as risk factors, like having a nasogastric tube, a history of migraines, or getting supplemental oxygen during surgery.
Good to know what doesn't count, too. C, strategies to reduce PONV-DNV risk. So, knowing the risk factors, what can the medical team actually do proactively to lower that risk? It sounds like just waiting for someone to get sick isn't the best approach.
Definitely not. Proactive strategies are key. The first thing is, if possible, avoid general anesthesia altogether and use regional techniques like a spinal or epidural.
Okay, avoid it if you can. What if you can't?
If general anesthesia is needed, using propofol for both putting the patient to sleep and keeping them asleep is a good strategy, as propofol itself has some anti-nausea effects.
Interesting.
Then try to avoid nitrous oxide, especially for longer surgeries, and avoid or minimize the use of those inhalation anesthetics, the gases.
Okay, try to stick with propofol-based anesthesia.
If appropriate, yes. Another huge one is to minimize opioid use both during and after surgery. Maybe use non-opioid pain relievers as much as possible.
Multimodal pain relief.
Exactly. Keeping the patient well hydrated is simple, but helps. There's even evidence that using a specific drug called Subudex to reverse muscle relaxation instead of the older drug neostigmine might reduce PONV.
Wow, even the reversal agent matters.
It seems so. Minimizing fasting times might help a bit too. But the absolute cornerstone, the real secret sauce, as you said, is using multimodal antiemetic therapy.
Meaning using more than one anti-nausea drug.
Yes, using at least 2 different antiemetics that work through different mechanisms. Because PONV has multiple causes, attacking it from different angles is much more effective. D, multimodal antiemetic therapy, the synergistic approach.
Okay, so this multimodal approach is really the gold standard. Why is combining drugs so much better, and what kinds of drugs are we talking about?
It's better because nausea and vomiting aren't triggered by just one single pathway in the body. There are multiple receptors and neurotransmitters involved: serotonin, dopamine, acetylcholine, substance P, list goes on.
Okay, different triggers.
Right. So if you only block one pathway with one drug, the other pathways can still cause nausea. By using drugs that target different pathways, you get a much more complete blockade. It's a synergistic effect. The combination is more powerful than just adding the effects of each drug individually.
Makes sense. Cover all the bases. So what are the main classes of drugs used in these combinations?
There are several key classes: corticosteroids, like dexamethasone, drugs that block dopamine receptors, like the phenothiazines or butyrophenones, droperidol, haloperidol, anticholinergics, like the scopolamine patch, the very common 5-HT3 antagonists are serotonin blockers, like ondansetron, Zofran, the newer NK1 antagonists, like aprepitant. Antihistamines can sometimes play a role too, and occasionally benzodiazepines like midazolam might be added.
Quite a toolbox.
It is. And the goal is to pick agents from different classes to maximize that synergistic effect and provide really robust protection. E, deep dive into specific antiemetic drug classes and mechanisms.
All right, let's get into the specifics. Can you give us the deep dive on each of these main classes, how they work, when they're given, any big pros or cons? Let's start with the corticosteroids, like dexamethasone. 1. Glucocorticoids. Dexamethasone methylprednisolone.
Sure. Dexamethasone, or Decadron, is extremely popular for PONV prevention. A typical dose is 4 mg given intravenously. Interestingly, it seems to work best if given after the induction of anesthesia rather than right at the end.
Why is that?
Because its onset of action is about an hour. So giving it early allows it to start working by the time the surgery is ending. Some clinicians prefer a higher dose, maybe 8 mg of A. At 4 mg, its effectiveness is actually pretty similar to ondansetron or droperidol.
And how does it work? Do we know?
The exact mechanism for its antiemetic effect isn't perfectly clear, surprisingly. Theories involve it inhibiting parts of the brain's vomiting center, maybe reducing serotonin levels centrally, or inhibiting inflammatory substances called prostaglandins. It likely works through multiple pathways.
Okay. What about side effects? Steroids sometimes have a bad rap.
That's usually with long-term or high-dose use. For single, low-dose used for PONV prevention, dexamethasone is generally considered very safe. A common concern was whether it might impair wound healing, but studies show a single dose does not increase wound complications.
That's good to know. Any side effects to watch for?
The main one is a potential temporary increase in blood sugar levels. This might happen 6 to 12 hours after the dose, especially in patients who already have diabetes or impaired glucose tolerance or are obese. The increase is usually modest, maybe around 40 mg/dL.
Okay, something to be aware of in those patients. How does its duration fit into that multimodal strategy?
This is a key advantage. Dexamethasone has a relatively long duration of action, maybe up to 72 hours for its anti-inflammatory effects, though the antiemetic effect might be shorter. This long duration nicely complements shorter-acting drugs like ondansetron. So the combination gives you both immediate and more prolonged protection. Methylprednisolone is another steroid sometimes used, also effective. 2. 5-HT3 receptor antagonists, serotonin antagonists.
Okay, next up, the serotonin blockers. Ondansetron or Zofran seems like the one everyone knows.
It really is the workhorse, often considered the gold standard antiemetic. It works by blocking serotonin at specific receptors called 5-HT3 receptors, both in the gut and in the brain's chemoreceptor trigger zone.
So it targets serotonin directly?
Exactly. The standard dose is 4 milligrams IV, usually given near the end of the procedure. It became super popular because it generally has fewer side effects compared to older antiemetics, like less sedation.
But you mentioned earlier there's a potential issue with the heart's electrical activity, QT interval.
Yes, that's the main caution. At higher doses, ondansetron can prolong the QT interval on the ECG. This creates a risk, albeit small, for a dangerous heart rhythm called torsades de pointe.
So high doses are avoided.
Yes. A single 32 milligram IV dose, which used to be available for chemotherapy patients, was actually withdrawn because of this risk. So we stick to lower doses like 4 milligram or 8 milligrams for PONV. And clinicians need to be extra cautious in patients who already have conditions that might prolong the QT interval, like heart failure, slow heart rate, or electrolyte problems, or who are taking other QT prolonging drugs.
Gotcha. And what about its duration? Is it good for that post-discharge nausea?
Its duration is relatively short, maybe 4 to 6 hours. So a single dose given at the end of surgery probably won't last long enough to prevent PDNV effectively. But again, combining it with dexamethasone really helps extend the coverage because of dexamethasone's longer action.
Are there other drugs in this class?
Yes, there are others like ranastron and dolastron, although 5-dolastron isn't really used anymore due to similar QTC concerns. A newer one is polonocitron.
Polonocitron has that different.
Its big advantage is a very long half-life, around 44 hours.
Wow, that's much longer.
Exactly. So polonocitron is often preferred when preventing PDNV is a major goal. Because it lasts so long, it's usually given at the beginning of the surgery. There's also a combination product with an NK1 antagonist called nitupetant.
Okay, and one last thing here. Serotonin syndrome. Can these drugs contribute?
Yes, there have been reports of serotonin syndrome when 5-HT3 antagonists are used concurrently with other drugs that increase serotonin, like SSRI antidepressants. It's rare, but something to be aware of. 3. Neurokinin-1 receptor antagonists, NK1 antagonists.
Okay, moving on to a newer class, the NK1 antagonists. You mentioned aprepitant. How do these work?
These drugs target a different pathway involving a neurotransmitter called substance P and its receptor, the neurokinin-1 or NK1 receptor. These receptors are heavily concentrated in key areas of the brainstem involved in the vomiting reflex, like the nucleus tractus solitaria.
So blocking substance P.
Essentially, yes. By blocking substance P from binding to the NK1 receptor, these drugs suppress the signals that trigger nausea and vomiting.
Are they effective?
Very effective, especially for delayed nausea and vomiting, which makes them valuable for both PONV and chemotherapy-induced nausea. Aprepitant is FDA approved specifically for PONV. There's also an IV form called fosaprepitant and combination products. They generally have a long duration of action too. Rolapitant, for instance, has an incredibly long half-life. 4. Butyrophenones.
All right, what about the butyrophenones? You mentioned droperidol earlier and the controversy.
Right. Droperidol, given in small doses like 0.625 to 1.25 milligrams, was a mainstay for PONV prevention and treatment for decades. It's usually given near the end of surgery.
How does it work?
It's primarily a dopamine receptor blocker. It works in the chemoreceptor trigger zone in the brain.
But then came the black box warning.
Exactly. In 2001, the FDA issued that warning due to concerns about potential QT prolongation and the risk of torsades de pointe, similar to the concerns with high-dose ondansetron.
Even at the low doses used for nausea.
Well, the anesthesia community largely felt the risk was very low at those antiemetic doses. But the warning recommended getting an ECG before use, which made it impractical for routine OR use. So its use plummeted in the U.S.
Is it still used elsewhere? Or is there an alternative?
It is still used effectively in many other countries. In the U.S., some clinicians turn to haloperidol, another butyrophenone, often used as an antipsychotic at higher doses.
Haloperidol for nausea.
Yes, in very low doses, like 1 or 2 milligram. Haloperidol also has effective antiemetic properties. It can be given at the beginning or end of surgery. And crucially, while it can also affect the QT interval, it doesn't carry that same black box warning, making it a more accessible alternative for some.
Okay. Any major side effects for these low doses?
They can potentially cause extrapyramidal symptoms like restlessness or muscle stiffness, but it's less common at these low antiemetic doses compared to the higher antipsychotic doses. They should be avoided in patients with Parkinson's disease, though, because of the dopamine blockade. 5. Transdermal scopolamine.
What about the patch, the scopolamine patch? How does that fit in?
The transdermal scopolamine patch is another effective option, particularly good for motion sickness, which translates well to PONV prevention. It's usually applied the evening before surgery to allow time for the drug to be absorbed.
The night before. Okay. How does it work?
It's an anticholinergic. It works by blocking acetylcholine signals, primarily from the inner ear's balance system, the vestibular nuclei, and other brain areas, to the vomiting center.
Okay. What are the downsides?
The side effects are typical anticholinergic ones: dry mouth, blurred vision, dizziness, sedation. You have to be careful with it in elderly patients or those sensitive to these effects.
When is it particularly useful?
It seems to be quite effective, especially for preventing nausea when patients are using PCA pumps, patient-controlled analgesia with opioids after surgery, as those opioids are a big nausea trigger. 6. Benzodiazepines, midazolam, lorazepam.
Okay, what about benzodiazepines like midazolam or Valium? I thought they were mainly for anxiety or sedation. Do they help with nausea?
That's been debated for a long time. Lorazepam has been used as an add-on for chemotherapy nausea. But recently, a couple of big meta-analyses in 2016 looked specifically at midazolam given before or during surgery.
And what did they find?
They actually found that midazolam was associated with a significant decrease in overall PONV, nausea, vomiting, and the need for rescue antiemetics.
So maybe they do have an anti-nausea effect.
It appears so. The proposed mechanism is that they might decrease dopamine's effect in the chemoreceptor trigger zone and maybe decrease serotonin release by acting on GABA receptors.
So why aren't they used more routinely for PONV?
The main concern is sedation. Giving a benzodiazepine near the end of surgery might make the patient too sleepy and prolong their recovery time or delay discharge. So if used, it's usually in lower doses earlier in the procedure. 7. Metoclopramide.
Lastly, metoclopramide, or Reglan. How effective is that?
Metoclopramide is generally considered a pretty weak antiemetic. It has some mild dopamine blocking effects, but you usually need higher doses, maybe over 20 milligrams, to see much anti-nausea effect.
And it doesn't last long.
Right, its half-life is very short, only about 30-45 minutes. So if you give it at the beginning of a long surgery, it's probably worn off by the end.
Any side effects or reasons not to use it?
Like other dopamine blockers, higher doses can cause those extrapyramidal effects, involuntary movements. It's also contraindicated in Parkinson's disease. And because it strongly stimulates gut motility, it makes the stomach empty faster. You absolutely should not use it if someone has a bowel obstruction. F. Clinical application of antiemetics.
Wow, okay. That's a lot of options, each with its own profile. So how do clinicians put this all together in practice? How do they decide who gets what?
They use established guidelines, often based on calculating a patient's risk score, using those factors we discussed earlier: female, history of PONV, non-smoker, use of post-op opioids, etc.
So they tally up the risk factors.
Yes. And for patients deemed to be at moderate to high risk, the recommendation is definitely to use multimodal prophylaxis. That means combining at least 2 drugs from different classes. For children at risk, combination therapy is also strongly recommended.
And that combination approach really works better.
The evidence is clear. The effects are additive, even synergistic. Combining interventions significantly increases the reduction in PONV risk compared to using just one agent.
Okay, so prophylaxis is key for those at risk. What if someone still gets sick despite the preventive meds? What's the approach to rescue therapy?
Good question. If rescue therapy is needed, the first rule is to choose an antiemetic from a different class than what was used for prophylaxis.
Don't just repeat the same drug.
Right, because presumably the pathway the drug targets wasn't the only problem, or the drug wasn't effective enough. You need to try a different mechanism.
Okay.
Also, if the PONV occurs within the first 6 hours after surgery, you definitely should not just repeat the prophylactic dose. The original drug is likely still in their system.
Makes sense. What if it's later than 6 hours?
If it's more than 6 hours later, you can consider repeating one of the prophylactic drugs, except for the really long-acting ones like dexamethasone, the scopolamine patch, aprepitant, or polonosetron. Since they last so long, another dose usually isn't necessary, and could increase side effects.
Gotcha. And for rescue, you want something that works fast, right?
Exactly. Rapid onset is preferred for treating active symptoms. The whole goal is tailored, effective relief while minimizing risks. 3. Psychiatric drugs and anesthesia, navigating complex interactions. 3. Psychiatric drugs and anesthesia. A. The landscape of psychiatric illness in surgical patients.
All right, let's move to our third major topic, which feels incredibly important and complex: managing patients who are taking psychiatric medications when they come for surgery. How common is this situation?
It's increasingly common. The prevalence of psychiatric illness in the general population is significant. We're talking about nearly 10 million adults in the U.S. with serious mental illness,
Wow.
and many more with conditions like depression or anxiety that require medication. Studies looking specifically at surgical patients found that about 16% were taking anxiolytics, anti-anxiety meds before non-cardiac surgery.
16%.
And even higher for antidepressants. 21% of non-cardiac surgery patients were on antidepressants.
1 in 5 on antidepressants. So this is definitely something anesthesia providers encounter daily.
Absolutely.
Does taking these medications or having the underlying condition affect how patients do after surgery?
It certainly can. That study found that using anxiolytic medication was actually an independent risk factor for having poor short-term outcomes after surgery.
Really? The anxiety meds themselves?
That's what the data suggested in that study. Interestingly, antidepressants were not found to be an independent risk factor in the same study. However, when you look specifically at cardiac surgery patients, the rates of depression and anxiety are much higher than in the general population. And in that group, depression and anxiety are clearly linked to worse outcomes. Longer hospital stays, higher readmission rates, more reoperations, and even increased mortality, both short-term and long-term.
So mental health status is absolutely a critical factor in surgical outcomes, especially in high-risk surgery like cardiac.
Undeniably, it underscores the deep connection between mental and physical health. B. General perioperative management principles for psychiatric medications.
That's a powerful connection. So what's the general rule for managing these essential psychiatric medications around the time of surgery? Should patients stop taking them beforehand?
The guiding principle now, and this is a really important shift from how things used to be done, is that most psychiatric drug therapy should be continued right through the perioperative period.
Keep taking them. Why?
Because maintaining these medications helps keep the patient's underlying psychiatric condition stable during the stress of surgery. Abruptly stopping these drugs can cause withdrawal syndromes, destabilize their mood or anxiety levels, and just generally complicate their recovery.
I seem to recall hearing that certain older antidepressants, like MAOIs, used to be stopped weeks in advance. Is that not the case anymore?
That's exactly the shift I'm talking about. Yes, historically, it was recommended to stop monoamine oxidase inhibitors, MAOIs, maybe 2 or 3 weeks before surgery, due to concerns about potentially dangerous interactions with anesthesia drugs.
Right.
But that approach is largely abandoned now. It was often impractical, and stopping MAOIs can cause significant withdrawal problems. The modern thinking is that we can safely adapt anesthetic techniques to accommodate patients who are taking these medications.
So manage the anesthesia around the psych med rather than stopping the med.
Precisely. It prioritizes the patient's psychiatric stability. But the absolute key to making this work safely is communication. Everyone involved, the surgeon, the anesthesiologist, the nurses, must know exactly what psychiatric medications the patient's taking, the dose, and when they last took it. Comprehensive medication reconciliation is non-negotiable. C. Understanding antidepressants in the surgical context.
Okay, let's dive into antidepressants specifically, since they're so common. What are the general goals when treating depression with these meds?
The primary goal isn't just to feel a little better, it's to achieve complete remission of symptoms. Partial response often leads to relapse. Once remission is achieved, treatment usually continues for another 6 to 9 months. That's called consolidation therapy to really solidify the recovery. And for people with recurrent depression, long-term maintenance therapy is often needed to prevent future episodes. 1. Select serotonin reuptake inhibitors, SSRIs.
All right, let's start with the most common class, SSRIs. Drugs like Prozac, Zoloft, Lexapro.
Right. Selective serotonin reuptake inhibitors. They're first-line therapy for major depression, widely prescribed. Generally, they're well-tolerated and considered safe compared to older antidepressants.
What are the typical side effects people might experience?
Common ones can include things like restlessness, trouble sleeping, nausea, diarrhea, headache, dizziness, fatigue, and unfortunately, sexual dysfunction is also the relatively common side effect.
Okay. Are there any specific risks or interactions that the surgical team really needs to be aware of with SSRIs?
Yes, a few important points. First, SSRIs can, in some cases, cause hyponatremia, which is low sodium in the blood. This seems to be more common in elderly patients.
Low sodium. Okay. What else?
There's a potential for increased bleeding risk. SSRIs work by blocking serotonin reuptake, and platelets actually need serotonin to function properly in clotting.
So they can affect platelets.
They can inhibit serotonin uptake by platelets. There was some earlier evidence suggesting a possible link between SSRI use and increased bleeding or adverse outcomes after cardiac or orthopedic surgery. However,
Yes. More recent data.
it's exactly. More recent studies, including one from 2020 looking specifically at heart bypass patients, found no increased bleeding risk associated with SSRIs. So the evidence here is a bit mixed, maybe leaning towards less concern now, but it's still something to be aware of.
Okay. Conflicting evidence. Good to note. What about stopping them suddenly?
Ah, yes. Discontinuation syndrome. Stopping SSRIs abruptly, especially those with shorter half-lives like Basal, paroxetine, can cause a range of unpleasant withdrawal symptoms. Nervousness, anxiety, irritability, weird brain zaps or electric shock sensations, dizziness, insomnia, confusion, nausea. It can be quite distressing. It's least likely with Prozac, fluoxetine, because it has a very long half-life.
So definitely shouldn't stop them cold turkey before surgery.
Absolutely not, unless specifically advised and managed by their doctor.
Any major drug interactions?
Yes, SSRIs can inhibit certain liver enzymes, the CYP450 system, which are responsible for breaking down many other drugs.
Cool.
So they can interact with beta blockers, benzodiazepines, some heart rhythm medications, potentially increasing their levels. And, as we'll discuss more, there's the risk of serotonin syndrome if combined with other drugs that boost serotonin. Also, citalopram, Celexa, and escitalopram, Lexapro, have a potential risk of prolonging the QT interval, though again, large studies haven't shown increased cardiovascular risk in depressed patients taking them.
So the bottom line, perioperatively,
Unless there's a very specific patient concern, the strong recommendation is to continue the SSRI throughout the perioperative period for stability. 2. Serotonin syndrome, a critical complication.
okay, you've mentioned serotonin syndrome a couple of times now. It sounds serious. Can you really break down what that is?
It is serious. It's rare, thankfully, but potentially life-threatening. It's basically a condition caused by having too much serotonin activity in the nervous system, both centrally and peripherally.
Too much serotonin. How does that happen?
It can happen from taking too much of a single serotonergic drug, like an overdose, but more commonly, it happens because of an interaction between two or more drugs that both increase serotonin levels or activity through different mechanisms.
An interaction is the usual culprit.
Most often, yes. The mechanism involves overstimulation of certain serotonin receptors, particularly 5-HT1A and possibly 5-HT2 receptors.
What kinds of drugs are we talking about here, besides SSRIs?
Oh, the list is worryingly long. It includes all classes of antidepressants, really SSRIs, SNRIs, TCAs, MAOIs, certain antibiotics, notably lanazolid, opioid pain relievers like meperidine, Demerol, fentanyl, tramadol, even methadone, over-the-counter cough meds containing dextromethorphan, migraine drugs like sumatriptan, Imitrex, drugs of abuse like MDMA, ecstasy, or LSD, even common antiemetics like metoclopramide, Reglan, and ondansetron, Zofran have been implicated, anticonvulsants like carbamazepine or valproic acid, herbal products like St. John's wort, ginseng, nutmeg, lithium, methylene blue, a dye sometimes used medically, buspirone, an anti-anxiety med, tryptophan supplements.
Wow, that list is extensive. It really covers a lot of common medications and even supplements.
It really does. It highlights why getting a complete medication history, including OTCs and herbals, is absolutely vital.
So what does serotonin syndrome look like clinically? What are the symptoms?
There's a classic triad of symptoms clinicians look for. 1. Mental status changes. This can range from anxiety and agitation to confusion, restlessness, disorientation, even hallucinations or delirium. 2. Autonomic instability. This means the body's automatic functions go haywire. You can see fever, hyperthermia, rapid heart rate tachycardia, rapid breathing, sweating, flushing, dilated pupils, high or low blood pressure, abdominal pain, diarrhea. 3. Neuromuscular hyperactivity. This includes things like overactive reflexes, hyperreflexia, muscle tremors, muscle rigidity or stiffness, and involuntary muscle jerks called myoclonus, sometimes even ocular clonus rhythmic eye movements.
That sounds awful. How quickly does it come on?
It can happen very quickly within minutes to hours, usually within 24 hours of starting or changing a dose of a serotonergic drug or adding another one.
And it can be fatal.
In severe cases, yes. Mortality usually results from complications like rhabdomyolysis, severe muscle breakdown leading to kidney failure, high potassium levels, blood clotting problems, DIC, or acute respiratory distress syndrome, ARDS.
How is it diagnosed? Is there a specific test?
There's no lab test. Diagnosis is based on the clinical picture and using specific criteria, like the Hunter serotonin toxicity criteria. These require the patient to be taking a serotonergic agent and have specific combinations of those symptoms we just discussed.
Is there one sign that's particularly suggestive?
Yes, clonus, those involuntary rhythmic muscle contractions, especially if they happen spontaneously or can be easily triggered by the examiner, or ocular clonus is considered a very important sign strongly associated with serotonin toxicity.
Okay, so if it's suspected, what's the treatment?
The first and most crucial step is to stop all the suspected serotonergic drugs immediately.
Stop the drugs.
Yes. For mild cases, that plus supportive care IV fluids, maybe benzodiazepines like lorazepam to control agitation and muscle issues might be enough. Patients usually improve quickly once the drugs are stopped.
What about more severe cases?
Moderate to severe cases require hospitalization, potentially in the ICU. They might need aggressive cooling for hyperthermia and sometimes even sedation, muscle paralysis, and mechanical ventilation if they have extreme rigidity or respiratory failure.
Is there an antidote?
There isn't a specific antidote, but a drug called cyproheptadine is often used as a first-line therapy. It's actually an antihistamine, but it also has potent anti-serotonergic properties.
Okay, so prompt recognition and stopping the drugs is key.
Absolutely. The prognosis is generally good if it's caught early and managed appropriately, but it's a powerful reminder of just how significant drug interactions can be. 3. Tricyclic antidepressants, TCAs.
All right, let's move on to another older class of antidepressants, the tricyclics or TCAs, like amitriptyline. Are they still used much?
They're used less often as first-line treatment for depression compared to SSRIs because they tend to have more side effects and are more dangerous in overdoses. However, they remain valuable options for moderate to severe depression that hasn't responded to other treatments. And importantly, TCAs, especially amitriptyline, are very commonly used at lower doses as adjuncts for managing chronic pain, particularly neuropathic pain, nerve pain.
Ah, for pain management too.
Yes, and patients often start feeling pain relief sooner than they would feel antidepressant effects, maybe within a week or two.
What are the typical side effects of TCAs that surgical teams need to know about?
They have significant anticholinergic side effects: dry mouth, blurred vision, constipation, difficulty urinating, confusion, especially in the elderly. They also commonly cause orthostatic hypotension, that dizziness when standing up, plus sedation and weight gain. Sexual dysfunction can also occur.
Okay, quite a few potential issues. Any major cardiac concerns?
Yes, that's a big one. TCAs can slow down electrical conduction in the heart, which can potentially lead to arrhythmias or irregular heartbeats. Because of this, they should generally be avoided in patients with pre-existing heart disease or certain types of glaucoma. Many clinicians will get a baseline ECG before starting a TCA or before surgery in someone taking one, just to check for things like a long QT interval.
How do they interact with anesthesia?
They can have a couple of important interactions. Because they increase levels of stimulating neurotransmitters like norepinephrine in the brain, they might actually increase the amount of inhaled anesthetic gas needed to keep someone asleep, increase the MAC.
Need more gas. Interesting.
Possibly. And more significantly, because they also increase norepinephrine levels peripherally, patients on TCAs can have an exaggerated response to indirect acting vasopressors.
Those are drugs like ephedrine used to raise blood pressure.
Exactly. If you give ephedrine to someone on a TCA, especially if they just started it, you might get a much bigger spike in blood pressure than you expect.
So what's the preferred way to treat low blood pressure in these patients?
If a vasopressor is needed, a direct-acting agent like phenylephrine, neosynephrine, is generally preferred. It works directly on the blood vessels without relying on releasing norepinephrine, so the response is usually more predictable. 4. Monoamine oxidase inhibitors, MAOIs.
Okay, now for the MAOIs. You mentioned earlier these used to be stopped before surgery but aren't anymore. Why were they considered so risky?
MAOIs, like phenelzine, Nardil, or tranylcypromide, Parnate, are older antidepressants, used much less now, mainly because of their safety profile. They have significant risks of interactions with certain foods and many medications.
The food interaction, that's the tyramine thing, right? Causing high blood pressure.
Exactly. Eating foods high in tyramine like aged cheeses, cured meats, certain beers, while taking an MAOI can trigger a dangerous hypertensive crisis. They also carry risks for serotonin syndrome, and dosing can be tricky. So they're usually reserved for treatment-resistant depression when other options fail.
How do they work?
They inhibit enzymes called monoamine oxidases, MAOA and MAOB, which normally break down neurotransmitters like norepinephrine, serotonin, and dopamine. By inhibiting these enzymes, MAOIs cause levels of these neurotransmitters to increase both centrally and peripherally.
Okay. We talked about serotonin syndrome risk with MAOIs already. What about other critical drug interactions?
The interaction with meperidine demerol is the classic, potentially fatal one we discussed. Causes severe excitation, rigidity, hyperthermia, absolutely contraindicated.
Avoid Demerol at all costs.
Absolutely. And you have to be extremely careful about combining MAOIs with any other serotonergic drug, SSRIs, SNRIs, TCAs, tramadol, dextromethorphan, St. John's wort, linezolid. The list goes on. There needs to be a washout period, usually at least 2 weeks, between stopping an MAOI and starting another serotonergic agent, or vice versa.
Okay. So, given all these risks, how is it safe to continue them perioperatively now?
It requires careful planning and communication. The modern anesthetic approach involves 1. Definitely avoiding meperidine. 2. Avoiding indirect-acting vasopressors like ephedrine due to the risk of hypertensive crisis. 3. If hypotension occurs, using a low-dose direct-acting vasopressor like phenylephrine very cautiously. 4. Being extremely vigilant about avoiding any other potentially interacting drugs, especially serotonergic ones.
So it's manageable with extreme caution and awareness.
Yes, but it absolutely requires that the entire team knows the patient is on an MAOI. Communication is paramount. Continuing the MAOI is generally considered safer for the patient's psychiatric stability than trying to stop it abruptly before surgery. 5. Serotonin norepinephrine reuptake inhibitors, SNRIs.
What about the SNRIs? Drugs like Effexor, venlafaxine, or Cymbalta duloxetine, how are they different from SSRIs?
SNRIs work similarly to SSRIs in that they block the reuptake of serotonin, but they also block the reuptake of norepinephrine.
So boosting both serotonin and norepinephrine.
Correct. They're used for major depression, anxiety disorders, and also commonly for chronic pain conditions, especially neuropathic pain like diabetic neuropathy. Duloxetine in particular is approved for that.
What are their side effects like compared to SSRIs?
They share many side effects with SSRIs like nausea and sexual dysfunction, but because of the added norepinephrine effect, they can also cause things like increased sweating, tachycardia, fast heart rate, and then sometimes urinary retention.
Anything specific to watch out for perioperatively?
2 main things. First, discontinuation syndrome can be particularly severe with some SNRIs, especially venlafaxine and desvenlafaxine, which have short half-lives. Stopping them abruptly can be really unpleasant.
So continue them if possible.
Yes. Second, SNRIs can cause a dose-dependent increase in blood pressure. So a patient's blood pressure needs to be well controlled before starting an SNRI, and it needs to be monitored carefully through our treatment, including during the perioperative period. 6. Atypical antidepressants.
And briefly, there are also atypical antidepressants, like Wellbutrin.
Yes, bupropion, Wellbutrin, is a common one. It works differently, mainly by blocking the reuptake of norepinephrine and dopamine. It's used for depression and also for smoking cessation.
Any key anesthesia considerations for bupropion?
The main one is that bupropion can lower the seizure threshold and potentially cause seizures, especially at higher doses or in patients with other risk factors. That's something the anesthesia team would want to be aware of. Other atypicals like mirtazapine, Remeron, or trazodone have their own unique profiles too.
Balancing bipolar disorder management with anesthesia.
Okay, let's shift to lithium. It's the classic treatment for bipolar disorder. What are the key considerations when a patient on lithium comes for surgery?
Lithium is still a cornerstone for maintenance treatment of bipolar disorder, often used alongside other mood stabilizers like anticonvulsants, valproate, carbamazepine, or certain antipsychotics.
What are the main side effects or potential toxicities of lithium?
Lithium has a fairly wide range of potential adverse effects. Common ones include tremor, increased thirst and urination, polyuria, swelling, edema, and weight gain. More seriously, it can cause confusion or ataxia, poor coordination, at higher levels.
And it can affect the kidneys and thyroid, right?
Yes. Long-term use can potentially cause kidney damage, things like tubular lesions or interstitial fibrosis, leading to decreased kidney function. It can also cause nephrogenic diabetes insipidus, where the kidneys can't concentrate urine properly, leading to excessive urination. This can sometimes be irreversible. Hypothyroidism is also a well-known risk.
So lots of potential issues. Are there important drug interactions?
Absolutely. Many common drugs can increase lithium levels, raising the risk of toxicity. This includes most NSAIDs, Non-steroidal anti-inflammatory drugs like ibuprofen or naproxen aspirin seems to be an exception. ACE inhibitors, common blood pressure meds ending in probal, and diuretics, water pills. These should be avoided if possible, or lithium levels need to be monitored very closely if they're used together.
And stopping lithium suddenly is risky too.
Yes, abruptly stopping lithium has been associated with an increased risk of relapse and even suicide. Any changes must be managed carefully.
It sounds like it requires very careful monitoring because of that narrow therapeutic window you mentioned.
Exactly. The difference between a therapeutic dose and a toxic dose is small. So regular monitoring is essential. This includes checking serum lithium levels, usually aiming for 0.6 to 1.0 milla-EQL for maintenance, maybe slightly higher for acute treatment. Levels are checked about 12 hours after the last dose. Monitoring thyroid function, TSH, and kidney function, BUN, creatinine, regularly, maybe every 6 months or so once stable. Watching closely for clinical signs of toxicity, vomiting, diarrhea, worsening tremor, lethargy, slurred speech, muscle weakness.
That's quite involved. How does lithium interact directly with anesthesia drugs?
It can have a couple of significant effects. It can prolong the duration of action of several non-depolarizing neuromuscular blocking agents. The muscle relaxants might last longer.
Longer paralysis, okay.
And it might also reduce the amount of inhaled anesthetic needed, reduce MAC, possibly by affecting neurotransmitter release in the brainstem. So the anesthesia provider needs to be aware that their standard doses of relaxants or anesthetic gases might have a more pronounced or longer effect in a patient on lithium.
Managing mental illness and surgical outcomes.
Finally, let's talk about antipsychotic medications. Patients with conditions like schizophrenia taking these drugs, what are the unique challenges during surgery?
Patients with schizophrenia or other serious mental illnesses unfortunately do face an increased risk of perioperative complications. This isn't just due to the medications, but also often related to coexisting physical health problems, maybe higher rates of smoking or other risky behaviors, an impaired stress response, and the potential for drug interactions.
What kind of complications are more common?
They might have higher rates of postoperative confusion or delirium, delayed bowel function, ileus, and potentially higher mortality rates. Also, if their antipsychotics are stopped before surgery, they can have a really hard time getting psychiatrically stable again afterwards.
So the recommendation is generally to continue these meds too.
Yes, for patients with chronic schizophrenia, continuing their antipsychotic medication through the perioperative period is strongly recommended for stability.
Can you briefly explain the main types of antipsychotics, typical versus atypical?
Sure, first generation or typical antipsychotics. These are older drugs like haloperidol, Haldol, or chlorpromazine, Thorazine. They primarily work by blocking dopamine D2 receptors. First generation or typical antipsychotics. Their main downside is the risk of extrapyramidal symptoms, EPS, movement problems like stiffness, tremor, restlessness, akathisia. They also carry a risk for tardive dyskinesia, TD, that potentially irreversible movement disorder, and neuroleptic malignant syndrome, NMS, a rare but dangerous reaction with fever and rigidity. On the plus side, their dopamine blockade makes them effective antiemetics, second generation or atypical antipsychotics. These are newer drugs like clozapine, olanzapine, Zyprexa, risperidone, Risperdal, quetiapine, Seroquel. They generally block dopamine receptors too, but often also affect serotonin receptors, 5-HT2A antagonism, and have more complex actions. Second generation or atypical antipsychotics. Their main advantage is a lower risk of causing EPS compared to the typicals. They're also thought to have a lower risk of TD and NMS, second generation or atypical antipsychotics. However, they come with their own set of concerns, particularly metabolic side effects. Many atypicals, especially clozapine, olanzapine, and quetiapine, are associated with significant weight gain, hyperglycemia, high blood sugar, and an increased risk of developing diabetes. There are also FDA warnings about increased mortality risk when used in elderly patients with dementia-related psychosis. Clozapine itself, while very effective, requires strict blood monitoring due to the risk of granulocytosis, a dangerous drop in white blood cells.
So, different risk profiles. What does the anesthesia team need to keep in mind when managing patients on either type of antipsychotic?
Key considerations include being cautious about hypotension, low blood pressure, especially during induction of anesthesia, as antipsychotics can sometimes lower blood pressure or have additive effects with anesthetic agents. Being aware of the potential for QT interval prolongation with some antipsychotics, so a baseline ECG might be considered. Knowing if the patient has a history of seizures, as some antipsychotics can lower the seizure threshold. Being mindful of potential issues with temperature regulation, given the risk of NMS, though rare, and other effects. Understanding that these patients may have altered pain perception or responses to stress, it really requires a vigilant and individualized approach based on the specific patient and the specific drug they're taking. Outro.
Wow, what an incredible amount of information we've covered today. We really took a deep dive into 3 critical, complex, and definitely interconnected areas of perioperative care.
We really did. From fighting those surgical site infections
To managing that awful postoperative nausea and vomiting.
and navigating the really intricate considerations when patients on essential psychiatric medications enter the operating room environment.
What stands out most to you from all this? For me, maybe it's just the sheer scale of the SSI problem, the billions of dollars and the human cost, or maybe the incredible precision needed for timing those antibiotics.
Yeah, those are huge. For me, it might be the fascinating interplay between brain chemistry and anesthesia, how a drug like lithium or an SSRI can fundamentally change how anesthetic drugs work in the body. It's complex.
The core message, I think, is that modern perioperative care is this amazing symphony, isn't it? It's highly specialized knowledge, meticulous planning, constant vigilance, and adaptation, all working together for patient safety.
Absolutely. And it leads to a provocative thought, doesn't it? As we keep developing even more powerful and specific medications for all sorts of conditions, how will the operating room of the future need to adapt its approach to pharmacology even further?
What new challenges will arise as we understand drug interactions and individual genetics even better?
Exactly. What new solutions will we need? It's an evolving field.
It really is. For now, though, maybe the key takeaway for you, our listeners, is just how interconnected all these systems are. And perhaps the most practical point, if you or someone you know is facing surgery, remember that clear, detailed communication about all medications, prescription, over-the-counter, herbal, everything is one of the most powerful things you can do to help ensure a safe outcome.
Couldn't agree more. Thank you for joining us for this deep dive.
Yes, thank you. Join us next time on The Deep Dive as we continue to unlock the vital knowledge that empowers you to be truly well-informed.